Hello and welcome to Single Payer Radio. I'm Paul Hoppe, broadcasting from the Habron Building in Louisville on the WFMP 106.5 Forward Radio Community Network. Our programs air every Monday at 2 p.m., Tuesday at 7 a.m., and Wednesday at 11 a.m. And we also stream our show on SoundCloud. The show is a project of Kentuckians for Single Payer Healthcare in conjunction with Physicians for a National Health Program through its Kentucky chapter. We produce this program because we believe healthcare is a human right. We advocate for a national, not-for-profit, publicly funded single-payer healthcare system that works for everyone. The views and opinions expressed on our show are those of the speakers and not the station. Our station relies on volunteers like myself and your ideas and donations to keep us on the air. Today, Doctors Mike Flynn and June Shively join me as co-hosts, and our topic today discussing issues affecting the immigration along our Mexican border, especially as related to providing health care to the immigrants. Gene has recruited a special guest to speak on the topic. Mike will get us started on the program. Mike?
This is Michael Flynn, a retired surgical oncologist from the University of Louisville. Let me begin with the usual disclaimer. Any comments I make represent my personal views. I do not represent the views of the Department of Surgery or the University of Louisville. Our topic today is migrant health care at the southern border. This is a very important topic, and we have a special guest from El Paso who will be introduced by Dr. Shively in just a moment. Gene, do you want to make a disclaimer before I move on to my next comments?
Yes, sir. This is Eugene Shively. I'm a retired general surgeon in rural Kentucky, in Campbellsville, Kentucky. I spent all my career at Taylor Regional Hospital in Campbellsville. And what I say does not reflect the views of Taylor Regional Hospital, nor the Department of Surgery at the University of Louisville.
All right, I want to make a comment to our listeners, and then Gene, I'll let you introduce our guest. Some of the issues and topics that discussed will represent a personal experience, and others will be referenced materials. And I would challenge our listeners to double-check many of the comments made today using whatever their preferred reference source might be. From a medical standpoint, the Journal of the American Medical Association, New England Journal of Medicine are good reference resources, as is the British Medical Journal, Wikipedia, and another option is Google search. So again, I would challenge our listeners as we go through these discussions and the various topics come up, if they have any questions about some of the comments we might make, or just have some disagreements or concerns, or just wanted to get more information, double check our facts. Gene, would you introduce our guest, please?
Sure. I would like to echo that. Please double check our facts. We just our program, just the last program, we had to make a edification and an explanation of something I said. So we're not always right, and there's always a difference of opinions. So, and in particular, there may be a lot of difference of opinions of what we're going to talk about today. I'd like to introduce Dr. Brian Davis, MD, and member of American College of Surgeons. He went to medical school at Baylor College of Medicine in Houston. He did his residency in general surgery. And as most of you may not know, that's a 5-year residency. He did that at the University of Louisville. And then he did an endoscopy fellowship at the University of Louisville. And then he went to Bethesda Hospital in New York City and spent a year doing fellowship in laparoscopic surgery, and then came back to Louisville with Dr. Gary Vitale and did a year of research in endoscopy. Brian has written over 68 peer review articles, and peer review means that these are articles that are submitted and they're reviewed by other experts in the field, mainly academic surgeons. I don't have time to go through all the accomplishments of Dr. Davis. I would like to say that he was just initiated into the Southern Surgical Association, which is probably one of the most academic organizations in the world. Brian, you want to tell us a little bit about what you've been doing, and then we can start with some questions.
Thanks for the great honor, Dr. Shively. I should let the audience know that Dr. Shively and Dr. Flynn were integral in my surgical education. I've been privileged to serve on the U.S.-Mexico border for nearly 16 years as a residency program director, as a trauma surgeon, and a general surgeon that did minimally invasive surgery for foregut and gastroparesis. And I'm very privileged to be in the Southern Surgical Association. And I've currently retired from my university position and shortly will be taking up general surgery practice in Corpus Christi, Texas, on the Gulf Coast.
Okay. Well, can you tell us, Brian, a little bit about the practice you've had in El Paso and a little bit more what you did? And then after you answer that question, tell us a little bit about the medical care that you had to give to the refugees and about the refugee problem with emphasis on the medical care in El Paso.
Thanks, Gene. I think I'd like to emphasize these are migrants. And as a native Texan, I don't fall on any political spectrum. We take care of everyone with the utmost compassion. And they're migrating up through channels in Central American Mexico and have been well funded and come to our country seeking employment and seeking health care. And it's a significant issue that is overwhelming many of our healthcare sectors. So I came on as an academic surgeon in 2008 to Texas Tech and University Medical Center of El Paso. Was on general surgery call and call at Level 1 Trauma Center. And what we've seen ever since 2008 is tremendous amount of cartel violence over the drug trade in our sister city of Juarez. And what I'd like to say is the tragedy that we're looking at with the migrant crisis is a human trafficking crisis, where the commodity is the people being trafficked by the cartel across the border into El Paso. And El Paso is the largest drug trafficking hub, largest center of migrant cartel activity. Unfortunately, people are caught in the middle and experiencing trauma. So in my role as a admitting trauma surgeon, ever since 2019, the American College of Surgeons said the on-call trauma surgeon takes care of every single trauma patient. So what we have in El Paso for a very large stretch is a 30-foot high border wall. Some people believe in the border wall, some people don't. If you travel 700 miles along the Rio Grande, you'll find out we're down in Laredo. There is no wall. People have to do what? We've seen the pictures in the media. They're outrunning Border Patrol on horseback. What are they doing in El Paso? They're crossing that border wall and falling 30 feet because it's a 30-foot wall. And some people say, well, why make it a 30-foot wall? Well, these are not chain link fences. They're not fences that are designed where people can easily climb them. So the other answer is it's a 3-story house they're falling from and experiencing severe injuries. And if people are young and you say, well, they're going to land on their feet, they might fracture their foot, they might fracture their ankle, they might have a fracture that is not causing problems with long-term morbidity, long-term disability, and long-term issues. But we're seeing a very severe cluster of injuries with heel fractures and ankle fractures, specifically for people landing on their feet from 30 feet. We are seeing a large number of pelvic fractures and head injuries because, again, we're seeing a migrant crisis of human trafficking. So when someone is in their 20s and 30s and they're climbing off a ladder on the Mexico side, and then falling 30 feet, the likelihood is they'll land on their feet. If they have other comorbidities, let's say they have obesity, let's say they have other medical conditions, they land on their pelvis, they land on their head, and then there's tragic long-term morbidity that's not being properly discussed openly as to why would people go to a 30-foot wall and be pushed off a ladder on the Mexican side to fall 30 feet when other people are making a conscious decision through cartel trafficking to go across the border in Laredo. And we know that Governor of Texas has placed barriers in Laredo and barriers in the Rio Grande River in those regions to partly prevent migration. There's a risk of drowning. Frankly, it's not considered a high risk because usually the Rio Grande is not high enough to cause problems. We also know there's a child trafficking crisis with 340,000 children. They're unaccounted for because we're unable to verify, are they traveling with families or are they traveling with cartel? Remember, the wall is not about keeping people out. It's focusing people in certain areas where they can cross, be verified, be validated, come to do things in the United States, because we have people every day that cross into the United States from Mexico for legitimate reasons to work in sanctuary cities that exist along the U.S.-Mexico border, where legally they are designed to be sanctuary cities so that people can safely cross back and forth for means of trade. Whereas within 90 miles of the border, there are checkpoints to determine that people do not cross northward into other places where, frankly, in cities like Chicago and San Francisco, they have horrible living conditions and I would say are treated as slave labor. So we see people fall off the border wall quite routinely, having major trauma from that. And there's also a second problem that can happen, which is when the human smugglers, which we, as a colloquialism, call coyotes, stuff 10, 11 people in a minivan and then try and outrun the border patrol on the U.S. side of the border. And unfortunately, chasing after those people does cause a mass casualty incident where 7 or more people can be injured in a car accident and present to the public county safety net hospital. In Louisville, University of Louisville takes care of all the Medicaid. Here in Texas, we have county safety net hospitals funded by the state and the city and the property taxes that care for everybody that does not have good access to insurance. So as a trauma surgeon, I can see people that are coming off of the border wall and falling, and I can see people that get caught in these high-speed chases with Border Patrol as well. Go ahead.
Brian, so give us an idea of what happens. So you see someone who falls off the wall who has a head injury or a fractured pelvis. So they're going to get admitted for a period of time. They're going to be treated. What happens next? Do they go into rehabilitation somewhere, or do you send them back across the border?
That's all funded by the state. So the difficulty, and I'm going to back up a little bit.
Sure.
This is a very well-known phenomenon in El Paso, in the border region. If a young person, let's say, is on the border bridge, and there are bridges between the U.S. and Mexico where people cross and have permits to work in El Paso or permits to work in adjoining communities, and they say, I'm here to work, they safely cross, they go to work, and they come back that next night. There are people that try and illegally migrate across that route and will jump from the bridge and sustain an injury. So a simple injury like a heel injury or an ankle fracture or a tibia fracture, they'll go into the hospital for 2 or 3 weeks, and the Border Patrol will not be able to stay with them for that entire time. So they will functionally sustain that injury, get surgery, and then cross into Texas after the Border Patrol has left the bedside, has left the hospital, and essentially anonymously migrate into the United States. So that's a known mechanism already. What we know is that people are being shuttled by the cartels. Cartels provide the ladders, and they think, well, if I can just survive this 30-foot fall, fracture an ankle, fracture my heel, fracture my foot, essentially, I've got access into the country, and we can move forward with the process of being employed by people that are employing migrants underneath the radar of the Border Patrol Service. And that's a known phenomenon. Unfortunately, people say, well, the wall was 20 feet, we built it to 30 during a previous administration. Now we're seeing catastrophic injuries. We're
Brian,
seeing the injuries because somebody's funding the ladder to get up to 30 feet.
Wow.
And
So
that's
yeah,
part of the tragedy.
Brian. So you're telling us that this is an intentional set of circumstances that allows a migrant to get into the country without having to go through any other process, getting an injury,
Correct.
getting into the hospital, getting treated, and then when the treatment is over, then they simply slip into they're in the country.
Well, and they're going to go to migrant sanctuary cities. And what I'd like to say about
Right.
sanctuary cities is it's a second tier of society, which is essentially slave labor, because the people that are undocumented migrants do not have rights. They do not have rights to medical care. They're presenting to overburdened public hospitals that do not have the proper funding to handle the flow. So what I would like to say is ever since 2019, University Medical Center, and I say this without any affiliation currently, is on overflow status and is on emergent status because we're having to store patients, ICU patients in the ER. So we're always on a hospital incident command emergency status because we do not have the capacity. We've not had the capacity since COVID-19. What we know is people were crossing from Mexico with COVID without documentation to receive care in the United States. And we know that the difficulty we're having providing care currently is that the hospital is overwhelmed by the number of trauma patients, specifically coming from border wall falls and other migrant issues.
I think Paul has a question.
Yeah,
Sure.
Brian, in your opinion, once these migrants get across the border and go through all this ordeal, even if they're hospitalized and medical treatment, and they finally get out and make their way into the United States, are the cartels involved in placing those people around?
I think that's a very interesting point. There's a great deal of speculation. We do know that people are paying large sums to cross through Mexico. We know these routes are not incidental, but they're controlled and these people are trafficked. And I do personally believe these people have connections to the cartel and maybe, working in other criminal capacities with the cartel stateside. Although I do not have good direct evidence for that.
Brian, what percent of your trauma patients are people coming over the border, or do you know?
I'd say we have a good 20% of the population that are coming as migrants, either falling from the border wall or they're being accidentally hit by motorists on the highway that goes along the border wall, or they're presenting as casualties or car accidents from the traffickers stuffing them into cars and then trying to migrate them northward from El Paso and other border regions. And that happens quite frequently too.
Now, Brian, how does all this 20% of migrant activity, which sounds like a lot of putting you into in an extreme circumstance of overwork, how does that affect your ability to provide health care basically to the local citizens?
I think it's a great question, Mike. So what we know is the volume of orthopedic care can be so high that people are going to go get their orthopedic care by American College of Orthopedic Standards and trauma standards within 24 hours of having that initial injury, which reduces infection and has benefits for other quality issues. What I will tell you is that if someone has acute cholecystitis, they may wait 5 days to have a cholecystectomy at an inpatient basis because not only is our emergency department overwhelmed with admissions, but our operating rooms are overwhelmed with orthopedic trauma due to this.
So if you have a patient who is in the hospital for whatever reason, and at some point they leave the hospital, if they have some other medical problem, is that something that they go back to the hospital in the emergency room or some urgent care center to be treated, or do they just not get treated? If they had a respiratory tract infection and need, this is a migrant who's fallen off the wall,
Sure.
gone through the treatment, and is now just assimilated into the country. What happens with their ability to get health care?
Well, I think it's a very good question, and it's a complex question. I'm going to start answering it in parts. So, if someone has an orthopedic procedure for an ankle fracture and they have to have pins placed, the burden on the hospital is because these people cannot be tracked and given outpatient care. They will stay the 2 to 3 weeks for the bone union to heal before they can be discharged so the hardware can be removed at the hospital. So not only do we face overwhelming conditions in getting people out of the ER, we face a crisis where we cannot get people out of the hospital because they cannot get follow-up care. And then they get follow-up care at any number of public safety net hospitals around this country, whether they're in Houston at Ben Taub, Dallas at Parkland, whether they're in the Cook County system in Chicago. We know that there are these incredible institutions that are incredibly overwhelmed with large numbers of migrants because we, as a compassionate society, take care of everyone independent of where they're from. I think that's a big thing for your readers to understand is we provide universal care. And I've worked in county hospitals in Houston, county hospitals in Dallas, and University of Louisville Hospital, and know that we don't have a mindset to check or verify before providing any level of care. And I think that's where the undocumented problem becomes an overwhelming burden competing with resources for people from underserved communities such as El Paso, where we all know if you have a sick gallbladder, you can't eat. If you have an inguinal hernia, you can't work. There are real disability adjusted life year issues when the local population has delayed care because the hospital's overwhelmed.
So, how do you finance all this? Is the city El Paso financing it, or the state of Kentucky, or both?
Well, I think that's a big controversy nationwide. So we all know that the Affordable Care Act was not adopted by every state. We know that Kentucky benefited greatly from the Affordable Care Act. So I can listen to you, Dr. Shively and Dr. Flynn, talk about how your rural hospital benefited and University of Louisville benefited from expanded Medicaid.
University of Louisville benefited great. Jason Smith just gave a talk, I think it was last Friday, about University Hospital, and when we expanded our Medicaid, there no insurance pay went, I think, approximately from 20% down to 5%. So that made a significant impact on University Hospital in Louisville and UK, and also to the hospital I work at, a rural hospital that's got a lot of Medicaid patients. I'm sorry I interrupted you, but I just wanted
of course.
Our audience
part of
to know.
What we need to think about with the audience is Medicaid is meant to support people that are either unemployed or underemployed that are part of that state system. So that's a documented system. So Texas Medicaid has a adoption of 30%, and that the county hospitals are funded through property taxes in the city. So the overwhelming burden is my property taxes, until I sell my house, are outrageous for the value of the property because I'm funding unfunded care through that property tax. It does not come federal or state. The reason Texas did not expand Medicaid with the Affordable Care Act was not because we did not want to provide care. What happened was we did not have a good handle on the number of undocumented because our border is so large that we cannot look at a cost-benefit analysis. And the cost-benefit analysis is, obviously, there is some migrant care at University of Louisville Hospital. When they drop it from 20% to 5%, what we're doing is taking care of the rural poor and the inner city population that are either unemployed or underemployed coming to University of Louisville Hospital. And by taking care of that 20%, it allowed a dramatic recuperation of funds for that 5% that may not have any funding at all. And what that means is they can hire more trauma surgeons, they can have better call coverage, and higher overall quality of care for Louisville because of that gap in funding mechanism. What we do not have is an ability to look at on a state-by-state basis, how do we meet that gap? Because your 5% that is possibly migrant working horse farms is my 20%, which is coming across a very porous border with no ability to document workers. And my argument is that we need to determine how people get better access to care, because as a documentation level, showing up in the emergency room is a horrible access point for quality care, for anything. It's
Well,
bad timing, bad access, high cost.
yeah, Brian, now the U of L is actually doing remarkably well, U of L Health, and it's a little more complicated than changes in Medicaid. First of all, U of L is now run U of L Health is not run by Humana, Columbia HCA, or Catholic Health Initiatives. These were three companies that were for whatever reason the board of trustees decided to try to have these organizations manage health care. Catholic Health Initiatives basically went bankrupt, and the whole Jewish system, which you will remember in Louisville, which included St. Mary and Elizabeth Jewish Hospital, the psychiatric hospitals, literally collapsed. A previous president of the university, Dr. Bedaputi, did a remarkably good job of collaborating with the state and a couple of Jewish foundations to provide a very large set of grants. And U of L Health now is self-governed, self-run. It is not for profit, and it has expanded the hospital based on the resources that they've brought in from providing health care, which doesn't involve paying a bunch of investors or a for-profit insurance company to run it. And the other thing that they did remarkably well was they incorporated the private practicing physicians in the Jewish system with the university system, the academics. And really, I mean, they did it really, really very well. And so it's a little more complicated than just a Medicaid thing. But I think the institution itself deserves credit for having put all this together and done a really good job at it.
Well, that's a very interesting talking point, Dr. Flynn, because the interesting talking point is the community pays. And when the community accepts a large amount of the undocumented care through the county hospital, we're sponsoring corporate welfare for publicly traded corporations. So I bring up the Affordable Care Act because Dr. Polk said it did great things for Kentucky. And the important part is it started doing something good by allowing some of these publicly traded corporations that were there for profit motives to be selectively moved out of an area that did not have very productive profit base for the United States. And everybody knows that Kentucky is not a great place to run a for-profit corporation. I compliment you with your description of how the university really has backed large grants to create a sustainable environment. And I'm moving from an overwhelmed university system to a nonprofit Catholic initiative that's buying up hospitals across rural Texas called Christus Health in Corpus Christi. And I have the exact same question. We need to have sustainable systems that benefit the community. We're not looking for Wall Street profiteering. We're looking for things that feed back into sustaining the community. And part of the migrant crisis is that if we don't have a way to ask very serious questions about where these people are receiving care, how they're being received into our country, how they're being treated by our country, who's employing them, and whether the employer should be held responsible for their health care. That's a serious issue because the whole right and privilege, we've decided if you work for the right corporation, you get great health care and you live longer.
Well,
If you don't work for a corporation, you fall on a second tier. And the second tier, when I was in training, was University of Louisville Hospital, where it was an overburdened, overworked public system. And that's what we're also seeing in El Paso. Plenty of people work, but they don't work for a corporation that can pay insurance. So they're falling in an overburdened county hospital where they're competing with migrants for medical care. And why are the migrants here? I wouldn't say it's the reason why I reject the word refugees. What war zone are they running from? So we look at worldwide, why are people showing up all across Europe in really cold areas? They're showing up for medical care. So they're migrating for the expectation that medical care is a right and should be provided.
wow.
And in the meantime, they're competing with a lot of other people that are native to our region at high expense that may have to wait 3 to 5 days to have a simple 45-minute cholecystectomy to go back to their normal life.
Yeah. Now let me
And in
ask.
the meantime, go ahead.
Yeah, let me ask you a kind of related question. You may or may not be comfortable with it, but I'm kind of curious. One of the aspects of modern healthcare that Gene and I have talked about on this program before is the invasion of healthcare by the wolves of Wall Street, private equity companies buying up nursing homes, physician practices, hospitals, hospital systems. So my question, again, this is not really directly related to the migrant issue, but it is related to some of these issues we've been talking about and that you've mentioned. How much of that exists in Texas, around El Paso, or any place else in the state of Texas, which is, as we all know, a very, very large piece of real estate?
That's a great question, and I'm not worried about answering it at all. What we know with private equity is there's a profit to be made, and we do know there is a lot of failure to treat that goes on when people that are uninsured or underinsured show up at private hospitals. And those patients tend to get pushed off to the county safety net hospital. And that's why I call it corporate welfare. So my property taxes are supporting the success of Wall Street created corporations. Do you know why? Because I'm operating on the gallbladder patients that have acute cholecystitis that are given antibiotics and pain meds and discharged from a private emergency room. And they say, well, nobody will operate on me, and they're coming to our county safety net for that surgery. So in essence, we have to decide why the profit motive goes to Wall Street and whether this is an acceptable standard of care, knowing what it really provides for the population. Because what it does is it delays proper surgical care, creates more disability for people that do not have access, and it also creates an overwhelmed safety net system for the public health resources. And I know I was overwhelmed and chose to retire because of largely the work burden. And I'm going to a nonprofit hospital also serving an underserved area in a rural part of South Texas. And they said to me, we're going to, as a nonprofit Catholic institution, buy up primary care practices so primary care doctors can stay in practice and work into their elderly years to help meet the gap for rural South Texas and other parts of rural Texas. So I swapped mission goals because I don't happen to believe that any place has the best answer. What we know is that many places in Texas and across this country are faced with the same crisis where the corporate hospitals are doing very well buying out and displacing patients to not necessarily a lower level of care. It's a level of care that is distressed, that is overwhelmed. The hospitals are overwhelmed. They're not properly funded by the state or the city. And it becomes an overall crisis of access to care
let me
because
make.
we're allowing this to happen.
Yeah, no, I'm going to ask you one more question, but I want to make a statement to our listeners. There's an article in the Journal of the American Medical Association that deals with this very issue that Dr. Davis has been talking about, the impact of private equity companies on healthcare, nursing homes, hospital systems, physician practices. Now, Brian, one more similar related question, not exactly related to the migrant issue, but related to these other issues we're talking about. We are currently on single-payer radio. This is a radio station, this is a radio program that is broadcast on Forward Radio, a volunteer radio station in Louisville. And this program is sponsored by a group, Gene and I and Paul all belong to it, Kentuckians for Single Payer, promoting Medicare for all. So then my question to you now, related back to your situation, how different would your situation be if we were in this what I would say is a very favorable set of circumstances where we had Medicare for all, which just for the benefit of our listeners, would be a federal government health insurance program, not something that runs the healthcare system, but simply government-run health insurance. How would that change your situation?
What I would say to anybody understanding our situation, in my position for nearly 16 years in the U.S.-Mexico border, is that the government would not know how to calculate a price tag, because if we provided care for everyone with a fluid open border, then the migrant crisis would worsen and people would come over here for every level of medical care. So I agree that I have this argument with my colleagues all the time. Socialism works great if you have population control. And I don't mean that in a negative aspect. If you know what your population is, you know what your industrial base is, and Canada has done this for generations, you can calculate out how many pacemakers can be given out. You can calculate out how many people can afford dialysis. We can calculate out what the benefit is to society, as long as we know what that population looks like, and that target changes every year. So if we close borders and say everybody gets a standard of healthcare, minimal standard, you get primary care to prevent going on dialysis, you get insulin, you get things that keep you in the workforce and keep you from losing limbs and life. And let's just look at that as a function of the price of insulin. We do government regulated controls. We take on that, and it dramatically reduces disability across the board. That is a great goal, but we have to really ask a serious question: who's paying for this? So the migrants are migrating here for two things. They're getting medical care, albeit not the greatest. It's at the county safety net hospital. They're being employed in jobs that can be done by Americans. The reason they're not done by Americans, citizens, is that the compensation is too low and the risk to bodily harm is too high. So we have to, ask questions and go, I'm functionally through my property taxes paying for the health care of people that are coming over here, non-documented, and being employed. So we're sponsoring corporate welfare on two levels. We're sponsoring corporate welfare by allowing the private equity hospitals to dump patients in an overwhelmed public system. And the other corporate welfare is we have whole corporations and industries that use migrants without proper access to health care. So it doesn't matter whether I'm sponsoring my county hospital with my property taxes or sponsoring
Grace John
chicken farms that are using illegal labor and not providing proper access to care. And we have to ask a really serious question: where's that tax going to come from that's going to pay for this system? Because what we've determined is, through Congress and sustainable growth rate, if the healthcare rises above our gross domestic product, we're going to essentially bankrupt the nation. Now, I will argue that military spending and funding to other military adventures has way surpassed healthcare. We need to have compassion for our own people. We also need to have a serious discussion in this country about how do we have proper corporate responsibility for a population that is getting inadequate care, untimely care, and is walking away with too high a problem with disability adjusted life years and shortened lifespans because they're not getting access to primary care. Surgical care, yes, not primary care.
Well, Brian, hang
Now,
on a second. Let me ask Gene. Gene, can you answer that question? We started out, with your financial information that 1/3 of the amount of money in healthcare in this country is not used to provide health care. So I'm going to ask you to address some of Brian's issues.
I think he's right, but there's one thing that I need to point out is that the defense budget is they're trying to get it up to about $900 billion. The U.S. health care amount of money, this includes everything, including private, is $4 trillion. Now, approximately a third of that money is wasted. But I mean wasted, for example, advertising, for-profit, excess money that we pay on drugs, and there are many, many other reasons that has nothing to do with health care and that we waste that no one else does. And if we could take that money and turn it back into actual health care, we could probably provide care for everyone except the migrants without increasing taxes. Now, I want to ask, I got 3 questions. First is, are there nonprofits working around the border in El Paso to try to help some of these patients, particularly in primary care?
So I would say there are quite a few nonprofits, including the Catholic Church, that believe in the migrant mission.
Okay.
Provision of primary care is not what they're looking at. So this is separate from medical care. They're providing assistance with people getting supplies and donations and food for transit once they get to this side of the border. Tragically, the cartels are covering the cost, and I do not believe there's any good assistance that's not cartel influence on the other side. And that's from my experience subjectively with the way the cartels have dominated our border region.
Okay. That leads to 2 other questions. One is, in your experience of dealing with these people, why are they coming across the border? Well, why are they going through such a life-threatening situation, going through the jungle in Panama and doing all these, risking their lives to come across the U.S. border?
Well, I think they're being told that they're going to come and have good access to jobs and good access to health care. And I think the difficulty becomes, if we look at the type of jobs these people are taking, those are not jobs we would want anyone on a civil rights human level to say we're okay with the level of risk, the living conditions, or the inhumanity. And that's why I call the sanctuary cities that are not on the border, that are not engaged with cross-border traffic, as slave cities, because the people are living in horrible conditions, not being treated well with bad access to care. I think they're coming here because they think that the next generation will have good access to education, good access to healthcare, good access to life and opportunity. If we remember, the biggest problem with long-term survival and success in many of these developing countries is access to healthcare, then even if they hear a rumor about that access, they will migrate, because unlike what I experience in my sister country, Mexico, which is a very culturally mineral-rich, economically dynamic work zone, if you have an elective condition and you cannot pay, you do not get repaired. So if you cannot pay for your cholecystectomy, your gallbladder removal, your inguinal hernia, your ventral hernia, you get to carry that disability without assistance. So it is worth making that journey from these developing countries just to say, if you fall under that misfortune, you're going to have access to subsidized care. And that's what we do. It's not necessarily free, but if you have nothing and you walk in the emergency department here, you do get care and the best care we can provide for an overwhelming situation. Oftentimes, it is absent primary care, it's delayed care. Complications are more frequent. We know that, and that's why I think we're not providing enough funding in Texas. I'm thrilled to hear that funding in Kentucky's improved. We're not creating creative paths to sustainable funding for the public health networks in Texas.
Now, my next question is you've referred to the cartel frequently. It sounds like you think the cartel plays a very significant role in all this.
Well, have you ever heard of a term called the narco state?
Yes.
Okay. So I say this as someone who is taking care of children shot by cartels in the streets of Juarez. They were innocent bystanders. I either think that the law in Mexico is fair and equitable with good access to human rights and health care, or I believe the cartel has a significant influence across the board in politics and policy based off of money. And that's where I believe that my neighbor is a narco state.
So you think how much control does the cartel have over the Mexican government?
Yeah, I agree.
Well,
I wanted to ask that question as well, Brian, because that. Can you, since you're there, you've been there for 16 years, if you could, answer Gene's follow-up question with the relationship between the cartels. I mean, are they buying off politicians, buying off police officers? I mean, how does it work that they have this much influence and power in a country that is supposedly very prosperous?
What a lot of people don't know about Mexico is a large conglomeration of over 30 states. And these states are not run under the same federal law. So we have constitutional protections and agreements through the U.S. Constitution that says Kentucky is going to have similar law to Texas as far as your ability to carry a firearm, to express your civil rights, to have property rights. All these things are agreed upon. On a state-by-state basis, they're entirely outside of federal regulation. Mexico has incredible, based off each state, tourism resources, mineral resources, oil resources that are not managed on a federal level. So the ability to buy off police, politicians, this is routine, and the military soldiers at Fort Bliss are not allowed to go into Mexico because the cost is too high, because you can be placed in prison in Mexico based off suspicion without just cause. It's a Napoleonic law which says you are guilty until proven innocent. We have a much different habeas corpus. You can be accused of a crime in the U.S. and then go free until you're convicted in a court of your peers. In Mexico, the police can throw you in prison because of a suspicion of a crime, and then it can take up until a trial hearing at their discretion when you get to leave. So there are wonderful areas for tourism in Mexico. It's pretty well known by Texans. There are places that are not safe or advisable to travel because the targeting by the cartels means that it is not a safe place for independent tourists or business people to travel without their influence. And that's why I say there are whole states in Mexico that are narco states. That does not apply to people that may want to go on vacation to Cancun. It does not apply to District Federal. But I know for the northern states that are on the U.S.-Mexico border, that is routine common knowledge among all Texans. They're not safe for travel, and we don't advise people to go there unless they know family or close acquaintances they're staying with.
I happen to find out, actually by accident, that we actually had narcotics people and active military in Colombia when they had the huge problem with the cocaine epidemic. And we at least partially solved that problem with the help of the Colombian government. Is it possible that we could just solve some of the border problems and the fentanyl problems and the problems at the border if we could work out an agreement with the Mexican government to try to control the cartel and the drug um, problems, and particularly fentanyl in Mexico.
This really brings up a very interesting point about the migrant crisis, Dr. Shively, and that was the previous administration worked very closely with Mexico to close the Mexico-Guatemala border. The migrant problem we're having is not between Mexican citizens in the United States. It is between people using that as a gateway conduit from Central and South America. So the difficulty we're dealing with is, unlike other countries, Mexico does not have federal control over their border states sufficiently to enforce a crackdown on the cartels. It's been attempted by several Mexican presidents with very poor results, and I would warn any new administration not to try and criminally target the cartels because of the amount of violence it would create. I think the answer is we need to develop proper policy to establish people that are going to safely work, and because they're safely working, give them tax permits to tax the corporations they're working for so they get better access to medicine on this side of the border. We should have, and I know Marco Rubio was working on this, and I said I wouldn't mention politicians. We need to have a way to verify who's going to come here, who wants to work here, and in the meantime, have them on where the corporations are taxed for employing these people, and then have them on a defined path for citizenship based off of a good, sustainable work record. And I think trying to close the border or attack the cartels is probably not going to be a good long-term option due to the length of the border and the amount of criminal activity occurring. What we have to do is stop this being a migrant criminal enterprise by investing in the border to create a self-sustaining, fundable migrant work taxation system. And if you pay the taxes within the decade, you stay out of trouble with the law, then we work on how do we sustainably get these people to fill needs in society and contribute to their own health care and really create a sustainable situation. That's why I think that the politics in Washington are completely off, because one group wants to open everything and one group thinks attacking the cartels or building the wall is the entire answer, which it's not.
Guys, I'm going to give us a 4-minute warning. We're got 4 more minutes and then we're going to be over. Let me make one comment, and Brian, maybe I'll get your thoughts about this since you've got more information about the Mexican government and the cartels. I've really learned a lot from you. We had a similar sort of situation here with the mafia, and it was addressed, by the FBI, and it seems to me, and I've felt this way, for a number of years, that I agree with you about the border and having some sort of sensible way to allow people to come here and work. On the other hand, I've always felt that as part of our foreign policy, we should be working with not just the Mexican government, but some of those other Central American countries where a lot of these people are coming from, to try to improve the situations down there so they don't come here. And I don't know that we're doing that. We're busy getting involved in wars in Ukraine, which I think was a terrible situation going on in the Middle East, and this stuff going on with China. But again, just expressing some of my get in. I don't want to do a rant about this, but I've always felt that one of our I wouldn't call it a foreign policy failure. It's just something that's not been focused in the foreign policy, is trying to get the Mexican narco state looking more like a democracy, something like the European Union.
Well, what I'd like to say with remaining time is that corruption is just a human condition. Taking bribes is the human condition. It exists all through Latin and South and Central America. To try and criticize it is one thing. We need to make it more profitable for people to go with a system of documenting trade, because what we're doing right now is we're allowing the criminals to thrive. We're allowing criminal enterprises to move products that are killing our families and children. And we know that if we simply had a way of documenting, controlling the flow, and getting the companies that are employing these people to pay part of the tax, that people, because they're not going to find great jobs in Guatemala. There's too much population, Nicaragua, all these Latin American countries. Improving their country, there's not the industry. We are the industry giant for this hemisphere. The problem becomes we're using people in a slave class labor in sanctuary cities not on the border because they cannot afford the ability to live with any human decency in Chicago. So they live with decency where I work because they can go have a house and own a house based off what they're earning in Mexico, based off of cleaning my operating room. And we accept that, but they can't do that in Chicago. That is why it is a form of slavery, because they have no quality of life. We have to say, if we give you access to work, access to quality of life, and we need help ratting out the cartels and the criminals, because the people, when they're given opportunity, I believe will choose to do the right thing and turn against the criminal organization. Right now, the criminals are making the profits because we are at a stalemate over how to safely treat these migrants with civil rights and how to hold major corporations accountable. And I would say the same thing for private equity and healthcare. That if we're going to call and have a debate over equity as a right versus a privilege, we have to bring up why are Wall Street hedge fund managers making money off of shuffling medical risk.
Well, listen, I couldn't agree more. And the problem is we're looking at in the next 4 years, this country is going to turn into an oligarchy. Gene, do you have any last-minute comments to make before we wind this up? I'll let you say something and then give Brian the last shot, and then we're going to wrap it up.
Well, I just want to ask one more question. It's a very complicated question, but I'm asking you to sum it up in a couple of minutes.
You got 30 seconds to answer it.
if I call Trump tomorrow and tell him that Brian Davis needs to be the czar of the border, and he agrees with me, then what would you do, Brian?
I think you need to treat every human like they're looking for care and work, and rely on the instinct of human nature to have them self-report and document and hold the politicians in Washington accountable for the lobbying and profit margin they're gaining by allowing what is essentially an illegal system on two ends. We've got illegal border crossing. We've got illegal utilization of labor tactics that function as slavery across the United States. And until we address both, we're not going to come to a solution.
Dr. Davis, thank you so much for offering to share your experience with us on the realities taking place on the Mexican border. This type of information is something you're just not going to get from corporate mainstream media. Thanks, Drs. Shively and Flynn, for putting this program together, and a special thanks to our listeners for tuning in. Please come back next time for Single Payer Radio.